Who joined. I'm excited to share this information, which is quite complicated and complex. So, just for all of the things we're going to do today, there's no test afterwards for you. The idea is we're presenting a lot of information, which then you can discuss with your physician or your nurse navigator or Erica or family, whatever. So don't feel like, all of these things you have to know about. Sorry. So we're going to start with some science. And I think many of you probably have heard of DNA and know a little bit about it, but it's kind of at the foundation for circulating tumor DNA. So I'm just going to give you a little overview of it. And so DNA is your body's instruction manual. It's called the double helix. It's this thing over here, if you could see my pointer. Genes are the specific instructions telling your cells how to grow, work, and repair themselves. Um, there's two sorts of genes that we talk about in cancer. One of them is germline inherited genes. People are born with it. It's in every cell of the body, can be passed on to your children, may have some cancer risk mutations like BRCA, and can help guide preventative care. The tumor has the same genes, but some of these genes are mutated or a little bit different. They have the wrong instruction. So they're telling things to grow when they shouldn't be growing. They're found only in your cancer cells. They're not inherited, and you can't give these tumor cells to your children. And it can help guide cancer treatment. So if we look at the diagram on the right, you see can you see my pointer? We see the normal cell and then its uh, instructions. And then we see the tumor cell, and we see that this tumor cell has a mutation, which is the star. And this is the information that's kind of gone awry. So what is ctDNA? So ctDNA is circulating tumor DNA, and it's in your blood vessel. So this is a picture of a blood vessel, and it has all different kinds of things in it, normal cells, and occasionally it has some things in it which are the bits and pieces of tumor from your tumor. So this is found in your blood from a blood draw. And they're small, rare fragments of DNA. They're released into the blood from a tumor during growth and death of the cell. And it's got the same genetic mutations as the tumor, so they can be quantified and analyzed. So how would you find it? And there's two different tests. Again, this is technical, but some of these words are words that you might need to know for working with your provider. So here you are, you're going to get a blood draw, and it's going to find the ctDNA in here. It's going in a tube. Then the next thing, it goes into a machine that whirls it around, and it finds the DNA for you. Then there's two types. One is called tumor informed. And so you could think of it, you're saying hello to the tumor. The blood is saying hello to the tumor. So the tumor is sequenced to find what its genetic makeup is, and it's matched to the tumor. And if the tumor and finds some things in the blood that it matches to, that's called ctDNA positive. So here you could see here ctDNA negative and ctDNA positive with the little star. There's another approach called tumor agnostic, where you don't need the tumor. And in this one, you just have a blood draw, and then different approaches to science are used, but the answer is the same. Is it ctDNA negative or ctDNA positive? So why might this be important to you? So you, like myself, I mean, I'm currently in treatment. And by the way, I want to just go back for a second. I got this tumor-informed test because I was worried about whether or not I was going to recur again. So I want to be clear that I'm talking, actually walking this talk of this talk. Um, so uh, so patients, including myself, are concerned about whether their treatment is working and if their cancer will or has come back. So one way to look at this, and I realize it's a very complicated chart, but the blue and the orange says, after my treatment, I don't have any ctDNA in my blood. And if that's true, I'm doing quite well. I should feel very comfortable. However, if your ctDNA over time in the various treatments are persistently positive, it means that there could be a poor outcome and the tumor could recur. But it's not like there's no drugs that could solve this problem, but it just means that the tumor could recur, but we don't even exactly know when it might. So this over time is called monitoring ctDNA, and it's, as we said, biopsy free. You don't need to, just a blood test for assessing risk and recurrence, and it's found earlier than on imaging. So imaging means mammography, MRI, PET CT, ultrasound. So it's the kind of earliest way before you have symptoms like a backache or whatever. And it might, if you're metastatic, enable the selection of a specific therapy. So here's a very colorful chart here about different phases of cancer it pertains to. So there's early detection, which is not ready for prime time yet, but we're hoping that we'll be able to use this to find cancer in your blood even before you have any symptoms. At diagnosis, particularly if you are in a clinical trial, and then in the phase pre-surgery, surgery, post-surgery being adjuvant, we'll use that term later, adjuvant, we can monitor the treatment. Am I finding any in my blood? And if present at diagnosis, does it lower during treatment? And that would be a good thing because that means the treatment is working. And then after you've taken your meds, you have a surveillance period, and if at that point you find ctDNA, that might point to metastatic or it might not. That's up to your doctor to determine that. And during metastatic treatment, it might mean, well, the treatment that I'm taking isn't working. Might I need to change it? So there are many, many things that we don't know about this test. And so what we want to know is its clinical utility. And what that means is, should we use it in patient care? And that's something that Dr. Kurian is going to talk about as well. And in order to really prove it, like everything else that we do in medicine, we have to validate with a clinical trial. And essentially, clinical trials can provide a chance to receive tomorrow's therapies and approaches today. So we recommend that you ask your healthcare provider if there are any clinical trials that are an option for you. So here's an example of a question that somebody might ask. So I'm taking endocrine therapy after surgery in the adjuvant setting, and if my ctDNA is negative, could it guide de-escalation if followed with surveillance? And what de-escalation means is, either reduce the dose or stop taking it. So we know that people are taking drugs like tamoxifen and others, and they might make them feel very sick. And so they would love to stop taking them, and they wonder, if it's ctDNA negative, can I stop my therapy? And there actually, people are trying to do clinical trials on this, but not ready yet. So here is on the right my ctDNA report. Fortunately, I was negative, not detected, But what the companies sent me was the result does not rule out the presence of ctDNA, and you really have to review the information with your healthcare provider. And right now, making this decision of this slide is very tough because we don't have enough information to safely justify stopping endocrine therapy outside of a clinical trial. And one of my colleagues at UCSF, a physician, said she was concerned that going back on endocrine therapy, in this case, when the ctDNA becomes positive, it becomes positive again, may not be enough to prevent recurrence. So you really have to, talk to your doctor. And most of the trials are for intervention. They're for ctDNA positivity, but not endocrine therapy if it's ctDNA negative. So quickly, so the question one might ask is perfection the enemy of the good enough? So here are 3 physician scientists at various academic medical centers. Some say the patient could benefit if they really understand the pros and the cons. Here's another who says it's like a CT scan, not perfect, but it can tell you whether or not you have cancer or not. And then here's a third person who is more prone to want to do things in clinical trials. So that would be the context of evidence. Evidence is clinical trial. And then he would explain the uncertainty. So there's a lot of barriers for oncologists. So my own oncologist didn't really want to do this. I had to go to somebody else. And why would that be? Because there's a limited understanding of it. Most tests are not yet FDA standard of care. So would it be risky for them to order? It requires shared decision-making with the patient. So that takes time in our busy world. What test should the doctor order? Who would review the results if she's not an expert or he? And what does the oncologist say to the patient about next steps when a positive result may not be actionable or a negative result may not rule out the presence of cancer? And I will turn this over to Dr. Kurian.
Well, thank you so much, Amy. That was wonderful. And I appreciate the opportunity to come in and talk about this. So I titled this slide, excuse me, I'm getting over a little cold. I titled this slide, What Are Oncologists Waiting For? Right? Because I'm sure this is very annoying to many patients. And I can imagine, that it's important to know, why isn't someone immediately signing on to this? And I happen to see in the chat people saying things like, oh, Kaiser hasn't told me about this. And, that doesn't surprise me because Kaiser is extremely evidence-based. And the truth is that we just don't have the evidence yet to make this routine. So one of the things I do when I'm not doing research and taking care of patients is I help to contribute to practice guidelines, which has been a privilege and really, really interesting to see how things get in there. And basically, the reason that routine monitoring with ctDNA is not yet in practice guidelines is really about this clinical utility question. Does it allow us to do anything that certainly will help the patient? Are we sure that acting on its results will make things better? And the answer is not quite yet, in my opinion. And I will tell you what trials I think need to happen to prove it, if I may. So I'm just going to talk a little bit about that. So I think this comes to this question of prognostic versus predictive. And you may hear this from oncologists who are trying to explain their challenges in getting behind this because it's tricky for everybody. But so the idea of a prognostic marker, some sort of a prognostic test result, means that it is associated with an outcome, regardless of treatment. So for example, if something has a poor prognostic or a bad prognostic association, it would mean that having a positive ctDNA test is associated with a greater chance of having the cancer recur and potentially dying of the cancer. So are we sure that that is true for ctDNA and breast cancer? I think we are. Amy summarized that nicely, and there are some other studies as well. I think they're pretty clear. Now, when I say associated with greater outcome, that does not mean 100% of the time, right? That may be that in some patients, for whatever reason, we might see a high ctDNA one time, and then if we check in a year, maybe it's gone. Why might that be? It could be that treatment has worked. It could be that the patient's immune system has taken care of it. You see me waving my hands because we don't know for sure, right? But it doesn't always mean if you have this, the cancer is going to come back. It just is a much stronger risk factor. So I think that's pretty well proven. The key thing that is not proven, which is the stumbling block for oncologists right now, is we need evidence that it is predictive of benefit. And what I mean by that is if I'm treating a patient and ctDNA is negative and then I check again and it's positive, I want to know that acting on that will make things better for her than if I had never measured and acted on it in the first place, if you see what I'm saying. So what we would then want would be to sort of say, okay, it gives us an opportunity to do what we would call intercept, right? Ideally would be this signal comes up before a person has back pain or before, a scan turns positive, and I can go in with a treatment and do something about it and make things better. That's the goal. And the only way to prove that really is with very directed clinical trials. So I'm going to just show 3 examples of the kind of trial I mean, just to help you kind of get a sense of where this goes. So a marker that you may or may not have heard of that some people know, and I mention it because it's very famous in breast cancer, is called Oncotype DX, or the 21 gene recurrence score. If a person has ER positive, hormone receptor positive breast cancer, often her oncologist will send this test. It's a test on the tumor. It's a DNA test on the tumor that gives a signature that helps us decide whether chemotherapy will be helpful to the person or not. And this is perhaps the most famous test, certainly in breast cancer and maybe in all of oncology, because it is both prognostic and predictive, and it works really well. So how did we discover that it was prognostic? We did that, not I personally, I admire those who did, but basically studies were done running sequencing on samples and following the people over time and observing that people with a high oncotype were more likely to have a recurrence than a low oncotype. But that doesn't help a patient. We want to know what to do about it. And so we had to do a randomized trial, which is the best form of evidence, the most scientifically rigorous, to find out whether you could make a decision based on the oncotype and people would do well. And so I'm just giving you a sense. This was sort of a famous study that came out in 2018 in the best scientific journal, which is the New England Journal of Medicine. And the point here is that they tested women. They tested more than 10,000 women with early stage ER positive breast cancer. And they had people who were very low score. They thought these people probably only need a hormonal or endocrine therapy. And very high score, they gave chemotherapy and hormonal therapy or chemoendocrine therapy. So that was sort of already known. But the important part here was in the middle. So what if your score is in the middle? We didn't really know what to do. And what they did was actually to flip a coin, and symbolically they used, random digit numbers or whatever, but randomizing people to, you have this intermediate score, do we give you chemo or do we not? And the patients were incredibly brave to do that, and I salute them tremendously. But this trial gave us an answer. And it showed us really unassailably with really clear evidence that in fact, when your score is intermediate, in a particular range, you do not need chemo and you shouldn't get it. And so when that happened, this became part of the guidelines and we order it on every patient because the data are so strong. So we need a study like this for ctDNA to help us decide, can we use it to make a decision? And I'm going to show you 2 examples that have already been done in other cancers and we need for breast. If you could go to the next slide. Okay, so I want to show 2 examples. Again, you see this famous New England Journal of Medicine, the really good science goes in there. This is an example in bladder cancer. So no reason something like this couldn't be done for breast cancer, and there are things in the works, but this is the kind of evidence that we're talking about. So the question here, it was kind of like in breast cancer, this was a person who people had had surgery for their bladder cancer. And the question was whether to give adjuvant treatment, so a treatment that comes after surgery to try to prevent recurrence. And in breast cancer, that might be anti-hormonal therapy like tamoxifen or an aromatase inhibitor, or it could be chemotherapy, or in some cases, immunotherapy. With bladder cancer, they use immunotherapy, but whatever it is, the principle is the same. So here what they did is they tested everybody in this study for ctDNA, and if the testing showed that ctDNA was negative, this is on the left, or rather the right side of the chart here, they said, okay, they're low risk. We're not going to assign any treatment. We're just going to follow them for recurrence. But then if it was positive, they said, all right, we're not sure whether we should act on this or not. The standard of care is not to give any treatment, but so we're going to see if ctDNA should tell us whether to do it. So they randomly assigned half the group to get the treatment, and they randomly assigned the other group not to, and followed them. And if you could show the next click, there we go. So what this shows, just to show you, and you may see this elsewhere, this is what we call a survival curve. And so here the y-axis is the percent of patients, the vertical axis is 0 to 100% of patients. And the x-axis is months since randomization, or the time that this has been going on. And so if your data were on, or if my data were on a figure like this, we would want to be closer to the top, closer to 100% freedom from whatever the thing they're measuring is. So here they're measuring disease-free survival, which is basically freedom from having the cancer come back. And so there are two lines here. The blue line is the study drug, which in this case was atezolizumab, but think of it as chemotherapy or endocrine therapy or anything else. And the gray line below that was placebo, was the people assigned to no therapy. These were all people with positive ctDNA. This is basically the left side of that figure. And what you see here is that the curves are separate. And what that means is that there's a difference between them. You can see daylight between them, and the group that's on top did better. And so that is evidence that clearly in this case, you should give this therapy, and you can do that based on the ctDNA result. Okay, and so what that proved is that ctDNA is not only prognostic, that if you test positive, cancer is more likely to come back, it's also predictive. So if it's positive, it predicts if you give a treatment now, things will go better. So that's the holy grail. Okay, that is proven for bladder cancer. We need that at breast. Fine to go next, because this is the other really important study design here. So the other really important one, right, just like Amy was saying, we do not want to treat people if we don't have to, right? We really would love to safely take treatment away if it's just doing more harm than good, but we need evidence. So they did this really nicely in colon cancer. You see the theme here of all these papers get into the best journal because they're excellent science. So here what they did is they took patients with stage 2 colon cancer. In stage 2 colon cancer, it's kind of like breast cancer. They do surgery, they take out the colon tumor, and most of the time they don't give chemotherapy, but it's sort of murky. And they tend to base it on things like, well, if it's maybe a little bit bigger stage 2, if it looks like it's a little bit more aggressive, maybe those things push us to give more chemotherapy. So here they said, well, what if instead of just looking at those features, we let ctDNA tell us whether to give the chemotherapy? So what they did here is they actually did randomization before even doing the ctDNA test, because they said, what we really want to test here is management with this test versus management without this test. So I think that's a really good trial, because it's sort of saying, is it better when you use this test for patients or not? So on the right side, they randomized people to no test. That's kind of like the standard. And they said, okay, well, according to our usual guidelines, if your tumor seems to be more rapidly growing, or if it's a little bit bigger or other things, we're going to give you chemotherapy. Okay, and then we'll follow you. On the side with the ctDNA, again, they're going to basically look at the results of ctDNA. So they've already randomized you to get ctDNA, and then they're going to act on it. If you're ctDNA positive, they're going to give you the chemotherapy, okay? If you're ctDNA negative, they're not going to give you the chemotherapy. And then they're going to follow you for recurrence. So instead of doing things like, oh, it's just the size, they're doing the ctDNA. So what I want to show you here, again, this is one of these recurrence-free survival curves. And I told you that if the curves have air between them, that means there's a difference and you want to be on the top curve. But here, there's no daylight between them, okay? And so this is really interesting, because what it means is that people did equally as well if you managed with ctDNA as without. But the kicker here is that the people who were managed with ctDNA got way less chemotherapy. Okay, so what this showed is that when you use the ctDNA, you spare a lot of people chemotherapy and it's safe. When you look at this curve, they did no worse, they did just as well, and yet they got to escape chemotherapy. So this is a beautiful study. We need it in breast cancer, just like we need the last one. And then everybody will order the test all the time. Great. So the next one, the next slide, great. So this is just a profile of some trials that are ongoing, and I'm not going to go through them all. This is a busy slide, but the point is that there are a lot of trials ongoing, of which I am glad, because we want to get to the point where we have strong evidence and we can order this in a way that helps people and not order it if it doesn't, is what I think. So the upshot here is that there are a number of different trials. I think Amy may talk about one of them, but they're enrolling, or some of them may have finished enrolling, but they're at various places. They're mostly here, at least in this study, for people who are ER positive, HER2 negative tumors, and they're trying to figure out what kind of anti-hormonal or endocrine therapy to give. So again, I won't go through a whole lot of this, but like if you look at the second one down, the DARE trial, which Amy will talk about, when people are ctDNA positive, they're giving them a more intensive endocrine therapy, so typically 2 drugs instead of 1, and I'll let her talk more. But many of the others are kind of like that. So, you're going to get endocrine therapy anyway. Should we kind of beef it up by giving it another drug or not? So I think those will be important, and we'll see. I'm looking here just at the one called SAFE DE. That's a little bit of the ways down. And so that's one where they're stage 1 HER2 positive or triple negative. And the goal there is to try to do escalation and de-escalation, right? So kind of like the last one we saw, there may be cases where if ctDNA is negative, you can do no chemotherapy and they'll be fine, but we have to test that. And that's what we're doing. So that's just an overview, and happy to talk more about them. But I want to now give it back to Amy to continue. And thank you. I think you're on mute, Amy. I'm sorry. I think you're on mute.
So I learned a lot from what you just said too. Thank you. So this is one of those trials on the huge chart called the DARE trial, and it's being run by the physician scientist who's the one that said, "I like evidence. I work off of evidence." Somebody from Yale is doing this trial, and so this is something that it asks the question: can it guide breast cancer therapy switch for high risk endocrine receptor positive HER2 negative patients? And these patients are high risk in this trial because they all have ctDNA positivity at the start. That's what's making them in part high risk. So it's asking the question, can before the patient actually becomes metastatic, can you head that off at the pass by switching from endocrine therapy? So for example, aromatase inhibitor to a different endocrine therapy, in this case fulvestrant, plus a targeted therapy, which is called a CDK4/6 inhibitor, like palbociclib, which I can never pronounce. And I'm not going to go to all that other stuff. All the findings are not in, but they have some interesting interim findings. And if you look at this chart, look at it like a Sesame Street chart. Which of these things is not like the other? And so down at the bottom, these people should be all doing well. They should be all green without relapsing because they have very low or they've seriously reduced their ctDNA. So they should all be green. But here's somebody who is ctDNA negative but relapsed. So that's why we're saying this test is not perfect. And the same thing in the other side, where these people have, some of them have very high ctDNA, some lower, but they all have their ctDNA was all above the line. And then you have this person, and she's green. So she had ctDNA positivity, and she did not relapse, at least in the period of time in which they, did this study. So it's just saying that right now, and it's true of actually many tests are not perfect yet. So here's some notes about the patient perspective and people that I've interviewed. And I want to reinforce the idea that every patient is different. They have different perspectives. I had a niece who had ovarian cancer who sadly passed away from it. She wanted to, and she also had breast cancer, and she didn't want to know about the science. She was an artist. She painted pictures, which she showed in galleries about cancer. So she would never do a test like this. So oncologists feel that patients might be too anxious to have this test because it's so uncertain. But some patients, and I put myself in this category, are already worried about resistance and recurrence. So maybe give them the opportunity. So here's somebody, a very smart advocate, triple negative, finished her adjuvant, and she said, no, I wouldn't do it because the results are not as accurate or actionable as you would like. Why freak out unnecessarily? And that's a perfectly reasonable response. And here's another person who feels it could be a useful diagnostic tool within the Black and Hispanic communities to try to get ahead of the game, give them the opportunity to consider it. So this person is with the Sisters Network and is actually also a nurse navigator. And so, she feels everybody should have the opportunity. And then here's somebody who's metastatic and she had complications from a CDK4/6 inhibitor, and she did the tumor agnostic test, and it was negative, and she felt that was sufficient to stay off and not risk further damage from another drug. The test isn't perfect, but better than endless worry. And there's a lot to be said about this particular perspective, but we won't go there now. So the key thing is that you and your provider, your navigator, your oncologist are partners in this decision, as you are in partners in all the decisions that you make. So the patient has to be a partner in decision making, and you might need some time to decide. Just discuss it with your friends, your family, and even your minister in some cases is useful, to talk about your care if they have some understanding of it. And it's key to include patients who might be less educated or economically challenged. And optimally, we would test in the context of clinical research, but patients may not have that opportunity and want off study. So I didn't fit in any clinical trial, even though I would have liked to have been in one. And so I just wanted it off study. So the key is to move forward with clinical research, improve reliability. It's not perfect. Advance consistency among the different testing companies, and also other biomarkers. If you can get other imaging, PET, CT, MRI, mammogram, if you still have breast, that's useful. That's shown to have a synergy. And hopefully we can have early detection. And so we talked about there's a simple blood draw. We want to monitor it. Managing expectations is important. And then hopefully, and this where it says cheaper than imaging, I mean, you also have to have insurance, right? Although some of these companies are willing to give it to you at a huge discount, insurance could be an issue. And I'm with Kaiser. Kaiser wouldn't touch it with a 10-foot pole yet. So hopefully the goal is to be actionable. Hopefully we will save lives by this knowledge and reduce fear. And I always try to finish my presentations by a memory of one of us who has passed away. And this is my friend and colleague, Carol Simons, who is a woman of indomitable spirit who worked with researchers to translate her own struggle into a better future for other breast cancer patients. May her name and others be a blessing. Thank you. Questions?